Hello friends, welcome to Medscope with Benson. Remember, this is part of our clinical medicine series of videos. If you guys love these videos, they help you learn. Please help us by subscribing, hitting down your like buttons, and sharing these videos. Now, without further ado, let's dive into the second part of the ARBs and the ACEs. That is the angiotensin 2 receptor blockers and the angiotensin converting enzyme inhibitors. My friends, we already talked about the first part of these ARBs and ACEs, where we looked into the RAS physiology and how, our ACEs and ARBs counter effects, or opposes the physiology of the RAS system that is in the mechanism of action, and at the same time looked into the examples of these ARBs and ACEs. Today, we want to look at the indications of these ACEs and ARBs, some potential side effects and contraindications to the ACEs and ARBs, my friends. Now, we already talked about this throughout all the mechanisms that entails on ARBs and ACEs. They help reduce the blood pressure. And in which condition do we have elevated blood pressure? Top on the list, my friends, we have hypertension. Now, the second aspect is the second indication, that is coronary artery disease or potentially a myocardial infarction. Now, these are patients who already, whose heart is heart is already weakened, and they have oxygen demand, increased oxygen demand. So when we give ARBs and ACEs, my friends, we help reduce potentially the afterloads and the preload, and that helps in or have clinical significance in coronary artery disease and the myocardial infarction. Same thing to heart failure as a third indication to the ACEs and the ARBs, my friends. Another aspect or another indication I would want to talk about are proteinuria kidney diseases. And in this context, my friends, I would like to talk about diabetic nephropathy, all right? Remember, in diabetic nephropathy, we have protein passing through urine. That's called proteinuria. And when we give ACEs and ARBs, my friends, we say they are nephroprotective. That is to mean they reduce the passage of urine, the passage of protein in urine, that is proteinuria. I also want to talk about cardiac remodeling, my friends. Now, remember, we talked about conditions such as myocardial infarction or chronic hypertension or potentially, heart failure. Now, we obviously know that renin is produced from the juxtaglomerular cells of your kidneys, and this renin helps cleaving your angiotensinogen, that's the protein that is produced from the liver, to angiotensin 1. This angiotensin 1 gets into circulation and gets into pulmonary capillary endotheliums, where angiotensin 1, through the enzyme known as angiotensin converting enzymes, that is the ACE, converts angiotensin 1 to angiotensin 2. Now, angiotensin 2 potentially increases the production of aldosterone from the adrenals, that is your zona glomerulosa of your adrenals, and the posterior pituitary glands, by also producing the antidiuretic hormone. Both of the aldosterone and ADH technically increases the reabsorption of sodium, and so is water. That increases our blood volume, which increases our preload, and that is likely to increase stress on our heart. My friends, we also know that potentially our angiotensin 2 is a potent vasoconstrictor. So it can act directly on our blood vessels that leads to what's called vasoconstriction. Now, with vasoconstriction, we increase the total peripheral resistance, and by increasing the total peripheral resistance, we increase the afterload, and by increasing the afterload, we increase the stress on the heart, right? Now, by giving our ARBs, the ACEs and ARBs, we potentially reduce the production of angiotensin 2, my friends. By reducing the angiotensin 2, we decrease directly by vasodilating, and thereby vasodilation of our blood vessels, and thereby directly reducing the total peripheral resistance, my friends. By reducing the total peripheral resistance, we reduce the afterload. By reducing the afterload, we reduce the stress on our heart, my friends. That prevents cardiac remodeling. Now, at the same time, when we also give angiotensin 2 receptor blockers in the ACEs, my friends, we also reduce the angiotensin 2. At the same effect, we have reduced production of aldosterone and antidiuretic hormone, so is the reabsorption of the sodium and potentially water. That reduces the blood volume, which is going to reduce the preload and so reducing what's called the stress on our heart. Now, we know that when there is increased stress, okay, when there is increased afterload and preload, that leads to what is called cardiac remodeling. So, my friends, other potential indications for our ARBs and ACEs is it reduces the afterload and reduces the preload, which potentially reduces the what's called cardiac remodeling. Now, let's talk about the potential side effects of our ARBs and ACEs. But in this context, I want us to concentrate. Okay, later on, we'll be concentrating on our ACEs, but let's see. Now, potentially, and in this context, I know you'll never again forget the RAS system. We keep on repeating them, my friends. Now, renin is produced from our juxtaglomerular cells within the kidneys, and this renin helps in cleaving off some amino acids from a protein that is produced from your liver, that is the angiotensinogen. And this angiotensinogen, is converted potentially into angiotensin 1. Now, angiotensin 1 gets into circulation, gets into the pulmonary capillary endothelium, where it encounters ACE enzyme. Now, ACE helps in the conversion of angiotensin 1 to angiotensin 2. Now, angiotensin 2, potentially, what it does is we want to concentrate on majorly aldosterone. Now, it stimulates our adrenals, that is the zona glomerulosa cells, to produce aldosterone. Now, aldosterone works on our kidneys, that is the distal convoluted tubule, to potentially increase sodium and water reabsorption, right? And when it does that, it increases our blood pressure through increasing or via increasing our blood volume. Now, another aspect is wherever we give aldosterone is it gets us excreting potassium, right? So eventually when we give the ARBs or the ACEs, my friends, what it does is it inhibits, as we already know, the production of angiotensin 2, right? When that happens, it therefore means that we will reduce, all right, the production of aldosterone. By reducing aldosterone, we have low sodium reabsorption and reduced water reabsorption. Now, that leads to obviously reducing the BPs. But on the other hand, we've said that when we give these ARBs and ACEs, my friends, we know that we are not going to be excreting enough of this potassium. And if that happens, then we'll be retaining more of the potassium, right? That would lead to what's called increased potassium levels in our blood, and that leads to hyperkalemia. That can lead to dysarrhythmias, which is characterized by the peaked T waves, my friends. Another aspect is wherever we're giving a lot of the antihypertensives, my friends, we must be watching for what is a potential side effects for them, and that is hypotension. My friends, I also want to talk about angioedema, right, which is a potential side effect for ACEs, not the ARBs, my friends. In this context here, I will take you through the bradykinin pathway, right, for us to get to understand better on how angioedema results from the usage or the indications that the usage of the ACEs. Now, we do have a protein that is known as prekallikrein, all right? Now, prekallikrein is converted to kallikrein, right, by two enzymes that regulate this particular process here, right? That is one, C1 esterase inhibitor, and two, one of the factor coagulation cascade factors, that is factor 12A, right? Now, factor 12A works by stimulating this process, that is the conversion of prekallikrein to kallikrein, right? But C1 esterase inhibitor works by inhibiting this process here. Now, this kallikrein works by stimulating what's termed as high molecular weight kininogen to bradykinins, right? Now, with the presence of bradykinins, my friends, it acts on our lungs and results into what is called bronchoconstriction. With bronchoconstriction, my friends, we can have cough and respiratory distress, right? At the same time, it can also work on our blood vessels to increase capillary permeability, and so is blood flow, right? Which can lead to what's called edema, and so is angioedema. It also acts on some of the nerves, and it can result to pain, my friends. Now, look at which enzyme helps to regulate this process, that is the production, to reduce the production of bradykinins. It is ACE, my friends. Now, if we give an ACE inhibitor, that means this ACE is not going, right, to inhibit the production of bradykinin, right? Because we are potentially inhibiting, right, the process, or rather the function of the ACE in the regulation of bradykinin. So that means this bradykinin will be stimulated, and so we are going to have cough. Patients will be presented with cough, respiratory distress. At the same time, they can have angioedema and potentially pain. Now, at the same time, my friends, we also have patients who have an autosomal dominant condition where they have C1 esterase inhibitor deficiency, my friends. Now, can you imagine what could happen if this patient has this autosomal dominant condition? That means they have a deficiency of C1 esterase. At the same time, they are on the ACEs. That is a potential contraindication, my friends. Now, let's look at what are some of the contraindications. Of course, we already talked about the angioedema. I don't have to repeat because you've already gone through the process that is as it is. Now, another contraindication is pregnancy, because we do not want to give ACEs and ARBs. They are potentially teratogenic, my friends. You might want to consider hydralazine, methyl dopa, labetalol, or nifedipine, as we already indicated in our hypertension video, right? Now, another aspect is when you give more of these ARBs, potentially, maybe they are on 2 or 3 antihypertensive agents, my friend, we are likely to tip them to hypertension. So you want to be careful on that. Another aspect is giving potassium sparing diuretics. Remember, an agent like spironolactone is a potassium sparing diuretic. So when we give it together with the ACEs and ARBs, we are potentially likely to worsen the hyperkalemia. Another aspect is NSAIDs, my friends. You'd want to be careful with NSAIDs in ARBs and ACEs, because NSAIDs potentially leads to what is termed as increased sodium and water retention, and that is likely to worsen, right? Giving them together with ARBs and ACEs. Another aspect is lithium. lithium is used in the treatment of bipolar, but wherever we give them with ACEs and ARBs, it makes it difficult in the elimination of this particular lithium, my friends. Now, we also want to be very careful wherever we have severe chronic kidney disease and potentially what we have already talked about, that is the C1 esterase inhibitor deficiency, my friends. Now, having said or gone through the potential, indications, the side effects, and the contraindications, that marks the end of our ARBs and ACEs, my friends. Until then, see you.